Hello everybody. Really quick, I'd just like to run through the past medical history as well as other pertinent details for the patient for my video intervention treatment. So first of all, my patient is a 64-year-old female who presented to the emergency department with progressive right-sided weakness, and eventually she was diagnosed with a left CVA, or stroke. Her past medical history overall was really unremarkable. She did have a history of being a diabetic for 7 years. However, it seemed to be well under control. She had no history of heart disease, so no hypertension, no heart failure, no carotid plaques or anything like that. So overall, she seemed to be a very healthy individual. Socially, she was married and lived with her husband in a 2-story home. However, for some time, she had been living in the first floor of that house. There were 2 steps to enter the home, so that was something that we needed to be aware of. She is a retired CFO from a medical company and has no children. All of her labs and vitals were within normal limits, so that's something that we didn't really need to focus too much on, just to be aware that they all were in fact normal. There was no neglect or apraxia, and all of her visual fields were full. She did have some mild dysarthria, but her speech was fully intelligible. She also had a little bit of spasticity in that right upper extremity. However, it was very mild, and mostly it was just what you expect to see with a stroke, mostly weak. All of her manual muscle tests on the affected side were below what you would expect to see in a normal patient. Cognitively, she had no trouble with perception or safety awareness. She was comprehending everything that was being told to her. Good motivation to do what she needed to do to get better, as well as no depression, and she was adjusting well to the situation at hand. So the limitation and activity that I chose to address, difficulty with gait. Again, that was the number one thing that she seemed to struggle most with after looking at her FIM scores, gait and transfers. So I chose to address gait. Reason being is that as a retired citizen, I'm sure that she would want to go back out into society and to do things in her community as opposed to just sit at home. So if she's able to walk independently, she can do much more than if she is basically bed or wheelchair bound. So we want to try to get her as functional as we possibly can. Again, that's the goal for every single patient we have. So the 2 impairments that I chose to address were number 1, poor standing balance, number 2, weak hip flexors and ankle dorsiflexors. The reason that I chose to picked those 2 things was, again, if you don't have good dorsiflexion and hip flexion as well, it's going to be a lot more difficult for you to walk, because those 2 things are very important for a normal gait pattern. And again, standing balance kind of speaks for itself. If you're not balanced on your feet, you're going to have a lot of trouble walking, as well as be unsafe and potentially run the risk of falling and being readmitted to the hospital for other issues. So what did I choose to address those problems? For the poor standing balance, I decided to do weight shifting in multiple planes. This is because with weight shifting, weight shifting is vital in order for you to have a normalized gait pattern. If you can't weight shift, it's going to be really difficult for you to walk normally. So not only will doing some weight shifting with me there, guarding her appropriately, not only will that help improve her balance, but because of approximating those joints that she's weight bearing through, we're going to get more activation of those muscles that are weak, and it's going to help her overall strength. Doing it in multiple planes also will help her prepare to walk and be able to react to her environment. Joint proprioception, again, is a big part of this balance training. And again, postural stability. So that is why I chose to do weight shifts. How was I going to address the weak hip flexors and ankle dorsiflexors? I chose to do PNF, D1 pattern for flexion, since she's, again, both weak in those things. If you're unable to hip flex and dorsiflex appropriately, you're going to have trouble with gait. So the D1 pattern in the lower extremity deals with both hip flexion and ankle dorsiflexion. Specifically, I was going to be using manual resistance with stabilizing reversals to further help her gain strength back in those muscles, and again do about a couple sets of 10 reps. So again, using PNF with manual resistance, that's going to help facilitate those muscle groups and give them more activation, as well as help her with some coordination and just try to get her back to the highest level of function possible. So again, those are the 2 interventions that I chose to do. Thank you.